the early 90s. There was I'll restart, I guess. In the early 90s, and before that, atherosclerosis, cardiovascular diseases, and hypertension were considered to be part of aging, and even there were some ideas that high blood pressure is essential for older patients to keep perfusion, and there were no actions to treat this atherosclerosis and hypertension and the other risk factors that we know now and that we treat now. So one of the major historical events that induced research and studies on cardiovascular risk and risk reduction and management is the history of the US President Franklin Roosevelt, who died of hypertension while he was in office. So after which a lot of things were decided. So he was diagnosed to have hypertension, but this amount of hypertension was considered to be normal at that time, but it gradually increased to the level of 180, 200 by 105, and then you can imagine a blood pressure of 240 by 130, what it can cause, and finally he died of cerebral hemorrhage with a blood pressure of 300 by 190. So like countless other people in the world, he died of the cardiovascular risk, hypertension, and its complications. But this led to establishment of the National Heart Institute and the beginning of the base of cardiovascular risk assessment, which is the famous Framingham study. So prior to this, as I said, aging in hypertension were considered to be normal. They were considered to be normal, and the upper limit for a person to be called to have hypertension is the age of the person plus the systolic blood pressure, which means if a patient he's 70 years old and his blood pressure, you can add, like the number would be crazy high. So as I said, after that, the study, the very long and large Framingham study was started, and progressively heart failure criteria was published. Systolic blood pressure was considered to be a predictor of cardiovascular disease. Then diabetes came into the picture to be a cause of increased cardiovascular mortality, and progressively lipid treatment, atrial fibrillation, and others came into picture, and that's how the advent of cardiovascular prevention and management came to picture. So cardiovascular diseases are major cause of death worldwide still, even after 80 or 90 years after this has happened. So 18 million deaths has occurred in the year 2070, and 70% of deaths now occurring in low and middle income countries are due to cardiovascular diseases. So this is one of the purposes of, yes?
Sorry, they're saying the audio is it maybe the earphone? Maybe can you try it without the earphone?
Oh, they can't hear me?
They're saying, I'm getting a lot of text on the message. They're saying the audio quality is not good.
Oh, okay. Okay, let me try it. Is this good now?
I think it seems better.
Okay.
For me.
Okay, you will tell me then. So I'm sorry, I was using an earphone, so I think it's better now. So cardiovascular diseases are the major cause of death worldwide, and their prevalence is increasing in low and middle income countries. And now most of the diseases occurring in such countries is due to cardiovascular diseases. During the past decade, total cardiovascular deaths has increased globally by approximately 20%. So this is one of the reasons why we're discussing this. Preventing these diseases accounts more to culminate this problem.
So global epidemiology, the prevalence, when it's compared from about 20 years back, it has doubled. About 270 million people had cardiovascular disease in 1990s, and now it's about 500 million, and the deaths also has increased significantly. Despite the major improvements in treatment than that time, there is also increased prevalence and increasing deaths. So as you see here, diseases from ischemic heart disease and stroke are number 1 and number 2 causes globally. This is a study published in 2016, and infectious diseases and other diseases come after that. So as you see, ischemic heart disease and stroke are the major cardiovascular diseases. They are accounting for much of the diseases worldwide. So when we come to our country, the national burden of cardiovascular disease and risk factors, the number of people affected by cardiovascular disease in Ethiopia is about 2.8 million in one of the studies, and 1/3 of this was rheumatic heart disease, then followed by ischemic heart disease and stroke. So ischemic heart disease and stroke and hypertensive heart disease are the 3 leading cause of cardiovascular disease in Ethiopia, and the mortality associated with this. So when this was classified to daily loss of lives, it's 170 Ethiopians die each day due to this disease, and this is why it's important to know how to prevent it. And diet and systolic blood pressure were the predominant risk factors that were identified in studies. So in comparison to our other African countries, our neighboring countries, Ethiopia has a little bit lower rate of cardiovascular disease and mortality, but it's still increasing with an alarming rate, which is an important issue. So one of the major surveys done in Ethiopia with a large scale, there are a lot of studies with variable results in rural and urban areas about the prevalence of hypertension, diabetes, and prediabetes. STEPS survey is done in relatively in uniform pattern, so it can be a very good reference. So STEPS survey showed hypertension prevalence of 16%, prediabetes 5%, diabetes 5.6%, smoking rate is 4.2, which is lower than other countries, but still would be significant for our country, and overweight is about 6.3%. We see the level and trends of standardized death rate per 100,000 by sex and age, as you can see over the years. Non-communicable diseases are progressively increasing. Since 2010, they have overtaken the communicable diseases in our country. So, WHO supports countries like Ethiopia in developing so that we can develop health financing policies, but there is no policy existing specifically for cardiovascular disease prevention. WHO recommends countries to have their own validated risk scoring and management guidelines, which we don't have currently. That's why we're going to discuss the risk scoring models of other countries. And this is one of the major drawbacks of this issue. So another weakness is lack of the sustainable funding. This is a global weakness. It's not only limited to our country. And lack of awareness about the non-communicable diseases and the effect of cardiovascular outcome is a major burden to the health and economy. So the suggested and the recommended thing to do would be to develop our own validated risk scoring methods. So prevention. So there is not yet a cure for cardiovascular disease, adverse cardiovascular outcomes. There is no cure, so we have to focus on prevention. Despite amazing improvements in treatment over the past 2-3 decades, still prevention is the preferred way of tackling the problem, and in order to do cardiovascular disease prevention, we have to first estimate the risk of a person to have cardiovascular disease adverse outcome in the next 10 years and or lifetime risk. And estimation, as you know, has its own limitations, and locally validated risk scores are recommended ones, because estimating risk score models have their own limitations, like they tend to overestimate the risk of a patient, and this increases the economic and side effect burden on patients. So that's why we have to analyze all the risk models and adopt the ones that are closer to us. So types of prevention in the most recent publications is classified into three. Primordial prevention is the prevention of development of the risk factors themselves. Primary prevention aims to prevent clinical manifestations of cardiovascular disease, and secondary prevention targets patients with already established atherosclerotic cardiovascular disease to reduce the risk of the recurrent events and to reduce mortality. So lifetime risk is the other concept. So lifetime cardiovascular risk estimates suggest that lowering the burden of cardiovascular disease requires all the above three types of preventions, and this is more for patients who are younger with multiple risk factors. For example, a young man with the diabetes, smoking, obesity will have cumulative exposure to these risk factors for a very long time, and his lifetime risk would be very high than an older patient with a new onset diabetes or hypertension, for whom we only calculate a 10-year lifetime risk. And so for younger patients, it would be substantial over their lifetime. So as you see, this is age versus the 10-year cardiovascular risk. So as age increases, there would be increased risk. And if there are risk factors, then it would be a cumulative risk on the lifetime of the patient. So this is a summary table for the stages of preventions for atherosclerotic cardiovascular disease. So primordial prevention is doing diet, lifestyle, environmental preventions in order to prevent the risk factors from happening to that patient. And once the risk factors has happened, the primary prevention should be done, and secondary prevention is for recurrence. And so this is something we have already discussed with a different approach. The only difference here is it has added policies and other social determinants other than the health factor. So the purpose of preventive strategies and policies is to shift the cardiovascular distribution to the optimal distributions and the one that's presently seen, which has a very high risk, and the plan is to shift this to a very lower one. So the chances of developing fatal or non-fatal myocardial infarction or stroke increase with the number of risk factors that the patients have. So various studies have already established this fact that a patient with very few or low number of risk factors have a very low risk, and those with high number of risk factors have high risk. So the higher the risk and the more intensive our interventions would be. And the other concept is the higher the risk is, the higher the benefit of our interventions also. So if we start a statin, a high intensity statin for a patient with a very high risk and a low risk, the benefit would be for that person with a very high risk than the low risk patients. So so the concept from this slide is, as the number of risk factors increases, the risk of developing disease is very high, and the benefit of treatment also increases with the risk. So this is also another way of seeing this. These are determinants of cardiovascular disease, which means total risk management approach is better than isolated risk approach. For example, if we see this is the reference population with the systolic blood pressure 110, 130, 115, 170. And with each added risk factor, the risk of developing 5-year cardiovascular risk per 100 people is exponentially increasing, as you see. So this here on total cholesterol level was added. So those with higher total cholesterol level have higher risk. If they are smoker, it would be very high risk. And with lower HDL, male, gender, addition of diabetes, and age, all they have a cumulative total risk on a single patient. So we have to assess all these parameters in order to help our patients. So team-based care approach is very effective. This is one of the things that's stressed on the current new guidelines, where clinicians should evaluate social determinants of health other than the laboratory and the physical examination that we do. So primordial prevention, as we said, is preferred. So the other issue about screening is, do we do opportunistic screening or systematic screening? Opportunistic screening is doing a general screening that takes only a few minutes for a patient who comes for another reason, okay? So patients might come to the hospital for some other reason, but we can use that opportunity to screen them for their cardiovascular risk and treat them based on their risk stratification. The other is systematic screening, which can be done on the general population or on subpopulations like diabetic patients, hypertensive patients, and with those with family history of premature cardiovascular disease. So systematic screening is a bit costly, and it's not something that's currently recommended. So opportunistic screening would be very wise, which means all of us, when patients come to our clinic, even if they're present for something else, we have to assess them as a whole. We have to assess all the cardiovascular risks that they can have. We can ask about smoking, which takes very few minutes. And if we're doing investigations, we can do fasting, lipid, and other things, and always see the blood pressure measurements that we get so that we can treat patients adequately. So this is what I took from the 2021 European Society of Cardiology primary prevention guideline, and it suggests systematic or opportunistic risk assessment in the general population should be considered in order to help patients. So this so risk estimation, the concept is done in an apparently healthy person, where the CVD risk is a result of multiple interacting risk factors. There is most of the things we have already discussed them. All risk estimating systems are relatively crude. They require analysis, and they tend to overestimate, so we have to personalize. So now we go to the risk estimation models. So there are a lot of them, and with each period they have been reevaluated and updated. So the Framingham, as I said, Framingham cardiovascular risk assessment study now has reached on the, I think, on the grandchildren stage. So they studied the first generation, then their children, offspring study, and now their grandchildren, so that they can see the genetic base of also the cardiovascular risk assessment. So the first was Framingham risk score, which was then updated recently in 2008. Then ATP3 score, pooled cohort equation, WHO charts. There are the European scores, score 2 and score 2 old person, and the Q risk and assign. So we're not going to discuss all of them because it's going to take time. I'm going to discuss the ones that are likely going to apply to our country, and Framingham study is the base, so we have to discuss it. So age, sex, hypertension, hyperlipidemia, smoking, diabetes, family history of cardiovascular disease, and obesity were identified to be risk factors for coronary heart disease from this very long, the longest running study of cardiovascular disease, which is Framingham Heart Study. And they were developed primarily based on white middle-aged men. The cohort study was based on white middle-aged men, and it predicts the risk of having coronary heart disease only in 10 years. It classifies people to low risk, intermediate, and high risk, and it may not be generalizable to diverse populations like our patients because the cohort study was not that diverse. But it's identified major risk factors that are listed here: smoking, hypercholesterolemia, hypertension, low HDL, family history, and age were identified as risk factors. So physical inactivity, obesity, and BMI, or physical inactivity and obesity were also identified as risk factors. So this is the updated Framingham 10-year total CVD risk algorithm. The first one was updated to have a better risk estimation. And we can use this also. So peripheral arterial disease, abdominal aortic aneurysm, and symptomatic carotid artery disease, diabetes were considered to have coronary heart disease risk equivalence. So when we analyze the Framingham risk score, it's well established. It's a very long running study. It has been validated in different populations. It has identified the risk scores, but the problems is it omits ethnicity. Hypertension patients who were on hypertension treatment were omitted, and family history of cardiovascular disease was not also included. And assessment of the risk of coronary heart disease only was the end point of this risk score. So it didn't encompass other cardiovascular disease outcomes like stroke or TI. So these are very important shortcomings. The other is the ATP3 risk estimator. I'm going to discuss this in one slide. So the difference from the Framingham is it included blood pressure treatment status, but then it also excluded diabetes and family history of cardiovascular disease, which makes it less reliable. And the endpoints assessed were the same as Framingham with coronary heart disease and non-fatal MI. Stroke and TIA were also not included. It included very wide age range with younger patients as low as age 20. So pooled cohort equation, it was developed in 2013 in United States by AHA. This is a very important one. It had a better estimate of 10-year and lifetime risk for heart atherosclerotic events. It included fair number of African Americans and women as opposed to other scores. And the age range is 40 to 79. And this is why we see this age range in most of our recent guidelines. The endpoints are occurrence of non-fatal MI or fatal MI or fatal or non-fatal stroke with also TIA. So it was validated in Caucasians and African American Blacks. Then later on, it was found to be overestimating risk in high risk in patients who are already high risk. This risk score method will overestimate their risk, and this has increased the number of patients that were put on high intensity statins. And in low risk patients, the threshold was 7.5 as opposed to the 5% that was seen in Framingham. So for borderline patients, this pooled cohort equation of AHA recommended to consider the presence of one or more risk enhancing factors in order to decide on treatments. So this overestimating risk overestimation was identified, and then the risk score was revised in 2018 with better inclusion and improvement of its overestimation. So when it was revised, it came as this one. So this is the revised form of the PCE cohort 2030, and this is now the mostly used risk score estimator, and it's derived from various cohorts that lasted for up to 12 years. It refined the calibration and corrected that overestimation risk on previous version. It included about 40% of Black population in the study, which makes it a bit closer to our case. And it also included the stepwise approach, which we are going to see. So this is the risks estimator plus. You can find it on, it also has an app. You can find it on your phone. So it's accessible, easy to use. It's an application. It even suggests therapy at the end of the risk estimation. It suggests therapy, which I'm not saying you have to use, but it's a well-validated risk estimator that we have now. So it's the stepwise approach in risk estimation is it estimates the risk using like the patient we have earlier, he came to our office, so we estimate the risk of that patient using this risk estimator, and we classify the category. So if patient is high risk, then there is we treat the patient as high risk. If low risk, we manage accordingly. But if patient is borderline or intermediate risk, then this is a gray zone where we have to add other risk enhancers. We have to look for risk enhancers and reclassify the patient. If patient has risk enhancers, one of the risk enhancers that I'm going to show you, then the patient can be reclassified into high risk. And despite that, if patient does not have risk enhancers and we're still uncertain, then there is a new thing that we can do, coronary calcium scoring. And with that, we can decide whether the patient should be on statin or not. So these are the atherosclerotic cardiovascular disease risk enhancers for patients who are borderline and intermediate risk. So if they have a family history of premature disease, the likelihood of these patients having a premature cardiovascular outcome would be very high, so it will push them to the higher side of the risk and for the treatment side. And the same for these others. So if patient has metabolic syndrome, primary hypercholesterolemia, CKD, preeclampsia was also associated to have increased atherosclerotic risk outcome. So if patient had history of preeclampsia, and these investigations can also be done if available in order to help us to decide whether the patient's high risk or low risk. So specific risk enhancers in diabetic patients are, so if longer duration, usually the risk in diabetic patients is already high. We're going to see the risks specifically for diabetic patients, but if they are fall into the intermediate one, we can use this end organ damage, target organ damage signs in order to decide whether the patient has high risk or low risk. So if patient has albuminuria, if the diabetes was a longer duration, especially for type 1 diabetic patients, if retinopathy, GFR less than 60, neuropathy, ankle brachial index less than, so if they have peripheral arterial disease, then this can help us decide whether the patient has high risk or low risk. So coronary calcium scoring, so it's a very good tool, but the benefit of CAG score is mainly to rule out. So it has a very high negative predictive value than a positive predictive value. So a score of 0 has a very high negative predictive value to rule out a significant coronary narrowing, and that will decrease our urge to start statin in a specific patient. But the problem is the absence of coronary artery calcium will not rule out an uncalcified plaque or a thrombus. So patients that benefit from doing coronary artery calcium is the ones I just said, those intermediate risk patients with no risk modifiers or patients who are intermediate and they are reluctant to use the statin therapy, they might not want to start. So in order to be sure, we can do this scoring method. And as you see, if it is 0, then we hold the statin therapy because the patient will fall below the threshold of statin benefits. And if it is between 1 and 99, we have to use we have to consider statin therapy now, and or use other risk modifiers. If it is above 100, it is above the threshold for benefit, and patients can be started with on statin therapy. So this is for asymptomatic patients. The use of coronary artery calcium scoring is for asymptomatic patients. It was not validated for patients with acute coronary syndrome or chest pain. And these are the studies that show that. So the other risk model is the WHO risk score model. Age, systolic blood pressure, smoking, systolic blood pressure, smoking, diabetes, and hypertension treatment history despite current normal blood pressure and cholesterol are included in this risk score model. It was primarily designed for resource-poor settings like ourselves, and it has two types. The WHO risk model has two types, lab-based and non-laboratory-based, which is the most important part of it. These are the cohorts that were included, the epidemiological subregions that are identified, and we are in the Eastern Africa region, and this is a non-laboratory-based risk chart. Our country has adopted this WHO non-laboratory and laboratory risk score method as and it's included in our guideline of national guideline of hypertension treatment and cardiovascular risk treatment. This is what we adopted. So non-laboratory, you can find it online because this might not be adequately visible. So the non-laboratory based risk chart is for areas where we don't have anything, like we can't do cholesterol level or fasting blood sugar. So these patients can be treated based on the risk factors like age, smoking, sex, and blood pressure. So these factors can be used to identify those who are at a higher risk and start their treatment. And this is the laboratory based, where it added total cholesterol on this one and diabetes on this one. Patients with diabetic and patients without diabetic. So this is how you go through this. This is found on the guideline, on the national guideline. Then we have to stratify patients based on the risk. So the WHO charts, they don't include family history of premature heart disease and obesity. This is one of the limitations. It's derived from a very large cohort studies, and it was corrected for low-income countries. It has a potential to underestimate in individuals with actual risk, like in individuals with diabetes. The non-lab based one will significantly underestimate their risk because they will not be identified and they have an actual higher risk. But the goal of the WHO was to pick at least 50% of patients that are at risk and that require treatment, and this is the goal that they have made. But when you come to the cities and where there is available investigations, this would not be enough. The 50% would not be enough, and we have to use other risk scores because it seriously underestimates the risk in diabetic patients. So just to see very few slides on the European risk scores, they are score 2 and score older person, and they are done on European patients. One of the strengths is they have included CKD, AFib, and rheumatoid arthritis. They have classified patients into 4 strata: low, moderate, high, and very high CVD risk. And this stratification came after the WHO classification of the CVD mortality rate published by WHO for each country in Europe. So it's only European based and it cannot be inferred to other populations or generalized to a population like ours. So if you see the European Society of Cardiology guideline, these are the scores that they suggest, but we cannot use them because they don't represent us. So this is the WHO risk, high cardiovascular mortality risk of the countries. So the red ones are the very high risk, and they used this one to derive their risk score method. So when we come to patients specifically type 2, specifically diabetic patients, so the loss that you can see is a moderate risk, right, in diabetic patients. So patients with diabetic without a known atherosclerotic cardiovascular disease or a severe end organ damage or not fulfilling the moderate criteria are in the high risk criteria, and patients with one of these end organ damage like GFR, microalbuminuria, proteinuria, and microvascular diseases like retinopathy and neuropathy, they are at the very high risk classification, and anyone with none of this would be the moderate risk. And in apparently healthy people, so anyone with age 40 to 79, they can be classified with the scoring methods. So this is the approach to use. I'm going to discuss that a little bit later on. So treatment approach. So now we have identified how to risk classify our patients. After classification, we have to treat them. So this is about primary prevention. So in all patients, the basic concept is to encourage lifestyle modifications to reduce atherosclerotic cardiovascular disease. Consider statin after risk classification. So class 1 recommendation to start statin is for patients with no risk factors. So we don't need to do risk factor assessment if LDL of a patient is more than 109. The class 1 recommendation would be to start that patient on high intensity statin. And the other class 1 is in diabetic patients with age 40 to 75. As we already said, even if they don't have any target organ damage or microvascular damage, they are already a moderate risk, so they have to start a moderate intensity statin. There are studies that have led to this idea. I will just include them in the slides. Consideration of high intensity statin in this population requires additional risk enhancers that we have already discussed. So after doing the risk scoring, if patient falls into less than 5%, which is low risk, then we discuss with the patient about cardiovascular risk. We advise the patient about primordial prevention, which means patient can prevent the occurrence of diabetes, hypertension by improving lifestyle, exercise, stop smoking, and dietary management. So this would be, so we do this. After this specific patient with low risk, we just don't let them go, right? Because risk assessment, it changes every day. We have to risk assess again. So in low risk patients, we assess them after 5 years unless they have any event in between. We reassess them after 5 years. Up to when do we do this? Like if the patient is like 50 years old now, we assess them every 5 years until they develop any atherosclerotic cardiovascular disease. Like if they develop MI or stroke, it would be a secondary prevention. But if they don't develop until the age of 79, because 40 to 79 is the age where the studies were, the study participants that were included. So we do every 5-year risk assessment, and if they still fall at the low risk, then we continue the lifestyle modification. Borderline and intermediate risk patients. So as you see, every table has a risk discussion with the patient. We have to clearly discuss the risk of the patient. We have to tell them in the next 10 years, this is your risk of developing myocardial infarction or stroke. And if we give you treatments like this, we can prevent this amount of the risk. So because every treatment has its own side effects, statins are known to have a higher risk of side effects. So risk discussion with the patient is very important. In these patients with borderline risk and intermediate risk, we use risk enhancers to favor treatment or to decrease the risk. So those patients with high risk, it's a class 1 recommendation to start statin therapy. And those with still, if risk stratification is not helpful, we can use coronary calcium scoring. So what are for low risk patients and for everyone, but for everyone, what we recommend is we recommend patients to adopt a Mediterranean kind of diet. This might not be applicable for every patient in our country because of the cost of living here, but at least they can decrease some of the added sugar and the added saturated fatty acids in their diet and focus on the more healthy ones, which are a bit cheaper in our country. So the guidelines recommend to adopt a Mediterranean kind of diet, which is less animal-based protein, decreased saturated fatty acids from diet, increase intake of whole grains, decrease trans unsaturated fatty acids from our diet. Salt intake should be reduced, vegetable intake should be increased, red meat should be reduced. If available, fish intake should be increased, and consumption of alcohol should be limited, and sweetened beverage should be strictly limited in these patients too. So from this, even if there is a higher cost of living, we can decrease the major ones like decreasing salt intake, decreasing sweetened beverage, decreasing alcohol intake, and increasing whole grains and vegetables, which are a bit available more in our country. So this is what we can advise our patients, and this is the summary of that. So adherence to this diet, why are guidelines recommending this diet, right? Like we should be curious, right? So adherence to this diet is associated with 10% reduction in cardiovascular incidence and mortality, and all-cause mortality is reduced by 8%, which is really significant for something that's achieved by diets. So this is just a schematic representation of what we just said. The sugars and trans fat have harmful change on the risk factor of a patient, so we have to decrease them. So the other is sedentary lifestyle. We have to advise our patients to increase their physical activity. And this is the light, moderate, and vigorous physical activity definitions. So as small as walking slowly and light housework can be beneficial, any exercise is better than no exercise. Any level of increment in the level of exercise, like in the intensity of exercise, is better than a steady state or sedentary lifestyle. So we have to advise patients anything that they can do. Older patients may not be able to run, but walking slowly might be enough for them. So any level of exercise is a good thing. If they can do it, moderate level of exercise is advised. Otherwise, any level of exercise is recommended. For a patient that wants to know the actual advised exercise, so at least 150 to 300 minutes per week of this should not be done on a day, but it should be done over the week of moderate intensity exercise, or 75 to 150 minutes of vigorous aerobic exercise can be done. And If they cannot perform 150 minutes, they can still stay active within their abilities. And so the purpose of this is it reduces all-cause and cardiovascular mortality and morbidity, which is a major thing that we are looking for. So the other recommendation is body weight. As we said, obesity is a major risk factor, and reduction of overweight or obesity is advised in all patients, especially those with type 2 diabetes, dyslipidemia, hypertension, and this. So obviously, so when we first identify patients, BMI should be done because it's the most studied and standardized approach, and then we follow them up with that, and it should be done on the primary screening. The other is smoking intervention. Smoking is like the most common cause of it. It's behind like 50% of diseases worldwide. It could be malignancy related, atherosclerotic, cardiovascular related, but it's behind most of the diseases. And all smoking should be stopped, and we have to strongly suggest that to our patients. So this is like a very brief example of what we can do. It can only take 30 seconds. We ask the patients whether they're smoking, and we establish the amount of smoking that they have been doing. Then we advise them, and then we offer help if there is if there is a program in our hospital or anywhere in the city, we can refer them to there so that they can help them to stop smoking. So it should be assessed in every patient. The other is hypertension. Discussing hypertension is going to take like another one full seminar. So I'm not going to go through that because it has its own guidelines, like diagnosis by itself. Diagnosis, risk factors, in the pathophysiology should be discussed by itself. But on the cardiovascular prevention front, patients with hypertension should be treated promptly with increasing, stepwise increasing and combining treatment in order to achieve the goal that's set in the guidelines. So in an apparently healthy person, we advise them to stop smoking. Other lifestyle modifications that we just discussed, if they are hypertensive, we treat their hypertension. Then we do their risk score method. I took this from the European Society of Cardiology guideline because it's the most recent one, and they are only recommending their own risk scoring method, but you can use any one of them that I just discussed. And we have to our goal should be to reduce hypertension, and LDL goal is less than 100 for apparently healthy person with moderate 10-year cardiovascular risk. If the risk is higher, then our LDL goal would be lower, less than 70, and then 55. We're just going to see that. So the other is we just discussed patients without any disease, just apparently healthy people, we just screened. The other is patients with already established cardiovascular disease like TIA, stroke, or peripheral arterial disease, or aortic aneurysm, or if they had acute MI, acute coronary syndrome, or stable coronary syndrome. So these are already patients who are established, and they are very high risk, and secondary prevention should be continued. So for such patients who are already established, then we have to recommend this one for everybody, the smoking and lifestyle. LDL reduction should be less than 70 for these ones. As we said, it is less than 100 for the other. And blood pressure control and antiplatelet therapy is considered in these patients because post-MI, post-stroke patients will automatically be on aspirin, clopidogrel, and other antithrombotic therapies based on their risk factors. So then after starting them on that treatment, then we see the residual 10 risk, CVD risk. and comorbidities, and then we plan to further reduce the risk of the patient by strictly treating them to systolic blood pressure less than 130 as tolerated by the patient, and LDL to less than 55. So cardiovascular risk in diabetes, it's very clear. They are classified into three main risks. We just had the slide: moderate high risk and very high risk. So for these patients, specifically for diabetic patients, we have to recommend them a similar thing, but with hemoglobin A1C target of less than 7 if they have established atherosclerotic vascular disease or severe organ damage, then they will be high risk. If not, they will be moderate risk, and we plan to reduce LDL to less than 100. For those with high risk, we have to plan to go to less than 55. So currently the consensus is that there is no lower limit of LDL level, which is previously it was thought to be unsafe to have a lower LDL, but currently as low as you can get it, the better for the patient. So we have to use a stepwise approach that I'm going to show you now for lipid therapy. So glycemia targets are this. Moderate intensity statin can be started for patients, and for the high intensity statin, risk scores can be added. So we've been talking about statin for the past few minutes, and what's the benefit of statin is moderate intensity statin can reduce LDL by 30%. High intensity statin reduces LDL by 50% from your baseline. And that was not enough for very high risk patients because they need further reduction of their LDL, and studies have been done by adding other non-statin lipid lowering therapies by adding them to high statin therapy. So one of them is ezetimibe. Adding that led to reduction of 65% from the baseline. And the newer medications around the block are the PCSK9 inhibitors, where by themselves they reduce by 60% when added with a high intensity statin, 75%, and if all three are added, we can reduce the LDL level to 85% with an associated reduction in cardiovascular disease mortality and non-fatal MI and stroke. So when we classify statin therapy, we just said moderate intensity, high intensity, depending on their efficacy. High intensity therapies are the most effective ones are atorvastatin and rosuvastatin with their higher doses. Moderate intensity are moderate dose of these medications, and the other statins also come at this level. Lower intensity ones are the less potent ones, like simvastatin, pravastatin, and lovastatin. So for our patients, especially for those who have a very high risk, we prefer the high intensity and the more potent statins, depending on the risk score. So as already established, if we start high intensity statin, if target not achieved, which is less than 70, and then if very high risk less than 55, we add ezetimibe and then PCSK9 inhibitors. So these are the studies. I have put them down here so that you can further refer to them because it would be a very long presentation to include them. So the other is antiplatelet therapy. Previously, aspirin used to be given for most patients with a higher cardiovascular disease risk, but studies have shown that patients with intermediate and borderline risks and lower risks, they have higher risk of bleeding than, so the bleeding risk outweighed the benefit of this aspirin. So nowadays the recommendation is 2B and class B. So for low and moderate cardiovascular risk patients, we don't give aspirin. Even for the very high risk patients, low dose aspirin, the recommendation is class 2B, where the evidences are not that strong, and it really have to be individualized based on the bleeding risk of the patients. Okay, so that would affect it would overcome the benefit of the aspirin. In the intermediate risk score, as I said, ASCEND study showed 12% risk reduction of developing a mild stroke, but significantly increased the risk of major bleeding, which outweighed the benefits, about 30%. And there are also other studies with similar findings. This is a graphic representation of what we just said. There is a 12% benefit of reducing serious vascular events, but major bleeding was higher. So we have to be really careful when we plan to give aspirin. It should be really individualized, even in those patients who are diabetic and high risk. We have to think twice and do bleeding scores. We have to know that if patient has higher risk of bleeding, then we don't have to give them. So in summary, so when we summarize, who do we screen? We screen apparently healthy patients with age 40 to 79, and those with risk factors. Then we risk stratify based on the risk models. So from what we have seen, the ASCVD plus estimator is the preferred one for those of us working in the CT, where we can access lipid profile and fasting blood sugar. But for physicians working in very rural areas, they can use the WHO non-laboratory method and assess their patients and treat them. And we have to always consider risk modifiers and repeat risk stratification in low risk patients every 5 years. Treat each individual based on the risk of lifestyle modifications and all of the things we discussed, and reassess the effect of your therapy and intensify accordingly for those patients who are very high risk. So we shouldn't be comfortable in a patient with a very high risk diabetic patient, more than 20% risk. If their LDL is under 30, under 40, we have to act further to intensify our treatment and reduce LDL level with associated reduction in CVD. So this is a summary table. So for statin benefit groups, so secondary prevention, anyone who had any event, this is the first statin benefiting group. The second is LDL more than 190, no need to do risk scoring, just we start them treatment. Thus, the other is patients with diabetes above age of 40 and LDL between 70 and 189, they should be started on the study. And patients who have not diabetic, but if their estimated risk score is more than 7.5, then statin therapy can benefit them. So these are my references. I hope everyone was listening to me, and thank you. If you have questions, the floor is open.
Thank you very much, Dr. Tigist, for your excellent and very comprehensive presentation on this topic. I think, can you hear me, Dr. Tigist?
Yeah, I can hear you.
Yes, I think we have a few questions on the chat box. One is from Dr. Kalab. Says how many risk enhancers are needed to reclassify patients to the high risk group, and that is one. And the other is probably after achieving our target LDL level, is there a possibility of de-escalation of the statin treatment, probably to a lower dose, if we are using it for primary prevention purpose? So if you can reflect on that.
Okay, thank you, Dr. Kalab and Dr. Abraham. The number of risk enhancers that are required, so the risk enhancers that we use are already on patients with intermediate risk. So any risk enhancer, like even one risk enhancer will make them a very high risk patient. For example, an intermediate risk patient with a family history of an early cardiovascular death will lead to very high risk, because they will also have a higher risk of having early cardiovascular disease. So the risk enhancers are any one of them can increase the risk of the patient, especially those who are the ones. I will share my slides again so that I can show you. Is it visible now? So from the risk enhancers, there are ones that are not strongly validated for all patients. Are you seeing them my slide? It's not visible?
It's not visible for me. Can you see it, Dr. Fusu? Or Ambessias, probably? Okay, I think they can see it, yeah. You can continue.
Okay, so so family history of premature cardiovascular disease is a well-established risk factor. So presence of that would be would make patients high risk. But those that are not strongly evidenced are, so ankle brachial index was studied, and its benefit was more for patients with female patients with intermediate risk. So it's for women with intermediate risk and with intermittent claudication. Those who have symptoms, ankle brachial presence of peripheral arterial disease has higher predictive value in them than other patients. So this might be an important issue. Elevated LP(a) is very important. It's a newcoming. It's a newcoming risk factor assessment model. Elevated high sensitivity CRP was studied in Jupiter study, where rosuvastatin was studied, and this is also important. So most of the risk factors can be used if one of them are present, can be used, maybe except ankle brachial index and race, which are more specific for fewer patients. It may not apply for everybody, and also the pregnancy and hormonal related. Otherwise, we can use the others to consider a high risk patient. I hope I have answered your question. De-escalation of therapy, I haven't seen any study that tried to de-escalate statin therapy after achieving the target LDL level, because I haven't seen any study, so I can't comment on this because we don't know the effect of de-escalation and if whether patients will have a rebound increment in LDL, or whether that will increase their mortality, or whether that would precipitate a new cardiovascular event. So because I haven't seen any study, I wouldn't be recommending de-escalation. The only de-escalation of statin therapy or replacing or replacing the statin therapy is for patients who developed myopathy and other major side effects. Otherwise, for the purpose of trial, I haven't seen any, so I can't comment on that.
Okay, thank you very much. So the other question is from Dr. Kananisa. When and how to stop antihypertensives in a patient on more than one antihypertensive agent? I think this would be a discussion of hypertension, which by itself is another
topic, but, it should be another topic by itself. Yeah. So hypertension treatment is it's a continuum of care where you control the blood pressure. there wouldn't be any need to de-escalate treatment unless patient is hypotensive or they are symptomatic due to hypotension. So it's a treatment given for control. So I don't think there would be any need to de-escalate. And maybe we discuss it more in another session.
There is a question from Dr. Antana. It says, do we do coronary calcium score in our setup? And if you have the experience, probably if you have seen it elsewhere as well, and how it is done, if you can say something on that.
So coronary calcium scoring can be done by the CT scan machines that we have. It will be started soon. The information that I have is it will be started soon. It's just a matter of trained personnel. Otherwise, we can use the same machine. And I haven't seen a report here, but when we do CT angiography, they try to see it's just that would be an angiography, but coronary calcium scoring is something we are not doing now, but will be started very soon because there will be a trained person soon.
Okay, thank you. So if you have additional questions, you can also raise your hand and ask Dr. Tigist directly.
So there is a question on the chat box that says DM and age 40-75 with moderate intensity statin. Is it regardless of the lipid profile level? No, the graph, it says if lipid profile is between 70 to 100, so if it is above 70, because our target for moderate risk patients is if it is above 70, to make it below 70. So that's the guideline.
Okay, so I think we don't have additional questions. Most of the chat box messages are appreciations, and they're thanking you for the nice presentations. And the audiences, please make sure to fill the Google forms to get your CEU credits. And again, we thank Dr. Tigist Seleshi for the excellent presentation and discussion on this very important topic. And we'll continue to have similar discussions in the future as well. So we, if you have, yeah, from Dr. Fissom, if you have further comments, I will leave the floor to Dr. Fissom.
The poll we did in the beginning of the presentation, we have sent it out again now to see if there's a change in your answers and how you have learned anything from the webinar. So make sure to fill out the poll if you can. TG, if you want to answer the questions for the polls, you can.
Yes, okay. Thank you all for voting. You have answered most of the questions. So the 10-year risk of having coronary heart disease for this patient is a intermediate risk. He falls in the intermediate when we use the pooled cohort, the new pooled cohort equation. He will be an intermediate risk patient, and as you rightly said, we use the pooled cohort risk model. If he was in the very rural area of Ethiopia, yes, we can use the WHO model. Because he's not diabetic, his risk won't be underestimated even if we use the non-laboratory model for this patient. And the management would be lifestyle modification plus moderate intensity statin therapy. And because he's intermediate risk, we don't need to give him aspirin or high intensity statin therapy.
So thank you very much once again, Dr. Tigist. If there are no further questions, or I think one last question probably, Dr. Tigist.
Okay.
Regarding the side effects of statin therapy, which one do we have to look for very cautiously after initiating statins?
Yes, thank you. So after initiating statin therapy, we have to look for the liver enzyme levels. It should be done frequently, like at least every 3 months to 6 months. And we have to ask patients whether they are having, so the most remarkable side effect is myopathy. So we have to ask patients about myalgia, and if there is any symptom, we can do a serum CK level. And the other side effect that we have to look for is what's identified is in patients with pre-diabetes, patients starting statin will, there is this increased risk of pushing them to be to the diabetic range. So pre-diabetic patients, if we are following pre-diabetic patients who are taking statin, we have to do their fasting and hemoglobin A1C frequently, because they can have a risk of developing, so they are already on a spectrum of developing diabetes, but those that are on statin have more risk of developing diabetes. So we have to follow them on that regard. For patients, so on the studies that higher number of patients were taking statin, there was a marginal increased risk of cerebral, like marginal increased risk of hemorrhagic stroke, but that was not specifically studied in those patients who are admitted with ischemic stroke or something, but for on the studies there was an increased risk. So in patients who have started statin, we have to look for the liver enzymes, ask patients frequently about if they have muscle symptoms, and if they were pre-diabetic, we have to follow their random blood sugar level, fasting and hemoglobin A1C. The studies have also tried to identify if patients who are already on diabetes because of starting statin, whether their diabetic control would be affected or not, but they didn't identify anything, which means those who are already diabetic will not be, their diabetic control will not worsen because they started therapy. So it's only for the pre-diabetic patients that we have to look out for and follow them. So, and we have to balance the risk of starting with the treatment with the risk of having the pre-diabetes itself, which is a risk factor for adverse cardiovascular outcomes. So we can start them, but just follow frequently for these things.
Thank you. So more questions are coming, I think, so we may need to extend the discussion by a few more minutes. From Dr. Getnet, the issue of statin therapy in patient with who is on hormonal therapy for malignancies and other indications.
Oncologic patients have a higher cardiovascular risk, but most of the cardiovascular risk assessment models have excluded, most of their cohorts have excluded patients with oncologic diseases. So we cannot suggest anything specifically for the specific treatment, like with a specific oncologic, the specific cancer or oncologic diseases, but these patients, they should be treated like any other patient. Their risk should be stratified, and statin therapy can be started after checking the drug-drug interaction with their therapies. Otherwise, most studies, they have excluded cancer patients because these studies are done for, like the Framingham study is very long, but the other cohort studies are done at least for 10 years, 12 years. So they exclude those who have higher risk of mortality.
Okay, thank you very much. So the recorded video of the session will be posted in our Tietenaux YouTube channel, so you can revisit the channel, you can check the materials, and you can also get the information from there. Make sure to visit Tietenaux Telegram, Twitter, and YouTube channels for other similar contents as well. And I would like to thank all who participated in this session. I would like to thank Dr. Tigist. Thank you very much. And thank you all. Have a good evening. Thank you very much.
Thank you. Thank you very much.